Alhamdulillah, salatu wassalamu ala Rasulullah. Good evening, everyone. It's my pleasure to moderate the last session of the SSBMT Webinar Series. Today, our topic is very important, how I treat CMV infection in allergenic stem cell transplant. And we are lucky today to have two distinguished speakers. First speaker is Dr. Mohsen Al-Zahrani, and second speaker is Dr. Tamim Al-Sulaiman. So I will start first to introduce myself. I am Marwan Shaheen. I am a consultant in adult hematology in King Faisal Specialist Hospital, Riyadh, Saudi Arabia. And I'm glad to present my colleague, Dr. Mohsen Al-Zahrani, who is section head of the Division of Adult Stem Cell Transplant and Cellular Therapy in Department of Oncology in King Abdulaziz Medical City, Riyadh, National Guard Hospital, the other name. Dr. Mohsen is well known in transplant field, especially sickle cell transplant. He's an author for many articles in this matter. And Dr. Mohsen will speak today about the burden of CMV infection or disease in the stem cell transplant. Before Dr. Mohsen will start, I want to thank our sponsor for today or tonight, Biotest. And also I want to remind everyone to write the question and answer in the Q&A place, so we can take the question and answer you later. Dr. Mohsen, please go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Marwan, for the nice introduction. And I would like to thank the SSBMT for inviting me to present today. I'll just share my slides. Do you see the slides, Dr. Marwan?
Yes, yes, I can see. Please go ahead.
Okay, so I'll talk about CMV infection and hematopoietic stem cell transplant, epidemiology, and clinical spectrum. This figure is well known to everyone. It is the phases of post-transplant, in which in each phase we have different type of complications and different infections. So the first phase is pre-engraftment, from the day of the transplant until the engraftment. And the main pathophysiology here is the neutropenia. So you expect to see the bacterial infections. In addition, you may see some other opportunistic infection, but mainly this phase is predominated by bacterial infections. The second phase, post-engraftment until day 100. So this phase is predominated by impaired cellular and humoral immunity, and the viral infection is the dominant infection in this period, especially CMV virus infection. And lately we know more about EBV virus reactivation also may happen in this period, and other viruses also may appear. In addition to some patients may have bacterial or fungal infection. After day 100, some patients may continue to have impaired cellular and humoral immunity, especially if they are having GVHD and if they are on immunosuppression. And here you will see the opportunistic infections, including fungal infections, viral infection, varicella zoster, and some encapsulated bacterial infection if the patient develop hyposplenism. CMV virus and hematopoietic stem cell transplant. CMV is a latent virus that belongs to the herpes virus group. It may reactivate in around 60 to 70% of CMV seropositive patients post-hematopoietic stem cell transplant. Primary infection also may happen in 20 to 30% of CMV seronegative recipient transplanted from CMV seropositive donors. And controlled CMV reactivation can lead to life-threatening multi-organ CMV CMV disease, such as pneumonitis, gastroenteritis, retinitis, hepatitis. CMV virus is the largest, large virus from the herpes virus group. Usually it causes latent infection, and it replicates very slowly in cell culture, mirroring it is very slow pattern of growth in vivo. It's excreted in urine, saliva, breast milk, cervical secretion. Also, it's present in the blood. So the method of transmission usually transplacental, prenatal infection of neonate, breast milk, blood transfusion, or organ transplantation, intimate exposure by mucosal contact with infective tissues, secretions, or excretions. The virus infection in general population varies, so depend on the regions of the world. So in general, worldwide is 83% of population, they are seropositive or get infected with the virus and they develop immunity. But in Europe and in America, the rate of the infection is around 60%, and in America 75%. In our region, Middle East, Africa, here in Saudi Arabia, 90% and above of the population, they are infected and they are seropositive. And this is very important for selection of donors and management of post-transplantation. This is one study, indirect prevalence of CMV infection in Saudi Arabia. This study, as we did about the sickle cell transplanted patients. So we looked to the donors of sickle cell disease patients, and we have two groups of donors, sickle cell trait and healthy donor. And the CMV seropositive of those donors, all of them, they are seropositive. So the infection rate in our population, at least the people coming from region with sickle cell disease, it's almost 100%. CMV infection characterized by latency after primary infection, which can be reactivated particularly in the setting of immunosuppression. Primary infection activates innate immune response, which causes the release of inflammatory cytokines. This process works to slow down the viral replication before the adaptive immune response develops to control the virus infection. Once the virus disseminates to cells of myeloid lineage, including monocytes, it establishes the latent infection. So the virus will live inside those cells for the rest of the life of the person. CMV specific CD4 T cells will appear after 1 week and will produce T helper 1 cytokines, including interferon, anti-molecular factor. This subsequently will stimulate CMV specific CD8 T cells, and it will become detected in peripheral blood, and it will become the effector memory T cells to control the virus and prevent reactivation. Once, so the virus live inside the body cells, leukocytes, monocyte, endothelial cells, under the control of those memory T cells to prevent reactivation. Once the T cells decrease or the function is affected, the virus may reactivate. Example, immunocompromised patients, organ transplant recipient, and individuals infected with HIV. And we have different types of CMV infection. So primary infection usually happen during childhood. It's asymptomatic, but sometimes some patients may develop like fever or mononucleosis like syndrome in immunocompetent individual. Then after that, the person will establish latent infection where the virus genome is inside the mononuclear leukocyte, endothelial cells, and organs in the absence of active replication of the infected virus. And this is similar to other herpes viruses. Reactivation may happen in a certain immunocompromised patient, and it is asymptomatic in around 10 to 40%. The detection here is by seroconversion or positive viral isolation test, example by PCR in the absence of clinical symptoms. Some patients may develop fever or constitutional symptoms. CMV disease, where the virus infect certain organs and will cause dysfunction, and localized disease may affect the lung, causing pneumonitis, or eyes, causing retinitis, hepatitis, colitis, encephalitis. Some patients may have disseminated disease, and symptomatic CMV infection may happen in 5 to 10% of hematopoietic stem cell transplant patient. Who will develop CMV reactivation? There are certain groups are very high risk to develop CMV reactivation. Those who are CMV seropositive, I mean the recipient, compared to seronegative recipient, recipients who receive T-cell depleted product, example in vivo or in vitro depletion by using ATG, alemtuzumab. Patients who develop GVHD, they are at high risk because they will be on multiple drugs to control the GVHD, which are immunosuppressive drugs. Donor type, there is mismatched donor, haploidentical donor, cord blood donors. They are at higher risk compared to match-related donor. I will mention some examples of CMV disease, like CMV pneumonitis. Fortunately, it is rare, but when it happens, it is a major complication. Mortality may reach 80 to 90%. But fortunately, with the current therapy, many patients recover, and up to 50% may expect complete recovery. The illness usually begins 1 to 3 months post-transplant. Diffuse bilateral interstitial infiltrate, as you see in the X-ray, will appear. We should consider bronchoalveolar lavage or open lung biopsy to confirm the diagnosis. And we have criteria establishing either proven disease or probable disease. So proven disease, the patient will have clinical signs and symptoms, plus the virus is isolated by tissue biopsy, while probable disease, the virus is isolated on BAL. CMV and gastrointestinal tract is the major complication that may happen from CMV, especially colitis, hepatitis, but other parts of the gastrointestinal tract may be affected. Symptoms will depend on the site involved. Endoscopy and biopsy is very important to establish here to look for the characteristic cytomegalovirus inclusion cells. So proven disease, if the patient is having symptoms and signs plus mucosal lesion plus the virus isolation and the biopsy. While probable disease, there is symptoms and signs plus viral isolation, but on endoscopy, the endoscopist may not see any mucosal lesion, just maybe erythema. CMV retinitis, which is rare to happen in post-hematopoietic stem cell transplant. This is more common in HIV patient, but it is known complication. And for a reason that we don't know, lately, over the last 2 years, we have at least 3 or 4 patients post-transplant who develop CMV retinitis. So the proven disease here require typical ophthalmological signs judged by ophthalmologist experienced with the diagnosis of CMV retinitis. So here you need an experienced ophthalmologist, and fortunately we have one in our center who is well experienced to diagnose CMV retinitis. If the presentation is atypical or an experienced ophthalmologist is not available, it is recommended that the diagnosis be supported by CMV documented in vitreous followed by PCR. Probable disease category should not be used, so we should confirm the diagnosis to start treatment, because the treatment is, in addition to the systemic treatment, we usually give local injection of the foscarnet or ganciclovir. The diagnosis of CMV infection, serology should be established before the going for transplant for both the recipient and the donor to determine the serostatus before the transplantation, because based on the serostatus of the recipient and the donor, we will select the best donor and we will plan for post-transplant management and prophylaxis depend on the serostatus. Virus isolation depends on the tissue involved, but frequently we do that on the blood, but also we may do that on organs involved. And the methods usually viral culture, CMV antigenemia on the blood, detection of DNA by PCR in the blood, histopathology, immunohistochemistry, and cytohybridization on tissues. Monitoring for infection post-transplant is part of preemptive prophylaxis. It's recommended that all allergenic stem cell transplant patients be monitored for CMV in peripheral blood at least weekly with either the CMV antigenemia assay or by testing for CMV DNA by PCR. The duration of monitoring should be at least 100 days. Longer monitoring is recommended in patients with acute or chronic graft versus host disease, or those who experienced an earlier CMV reactivation, or those who have haploidentical transplant or mismatched transplant or MUD. Start antiviral therapy with ganciclovir or valganciclovir as the first choice if virus is reactivated as detected by rising PCR titer or antigenemia. So the preemptive therapy, it's a method of prevention for CMV reactivation post-hematopoietic stem cell transplant, where serial testing for CMV by PCR or antigenemia on the blood, as I mentioned in the previous slide. This approach has been shown to decrease the incidence of CMV disease and improve survival. The alternative is to start prophylaxis post-transplant with ganciclovir or valganciclovir or very high doses of valacyclovir, but the side effect will be cytopenia. And we know both hematopoietic stem cell transplant patients usually have weak graft and may have significant toxicity from this drug. So it's preferable to do the preemptive therapy or prophylaxis. This is a study published from our center, which is the optimal preemptive cytomegalovirus therapy threshold in patient population with high prevalence of seropositive status. So as I mentioned previously, the seropositive status in our recipient and donors is almost reaching 100%. So we aimed from this study to determine the titer of the CMV in the blood at which we'll start the treatment. So our protocol is to weekly test for CMV viral load by PCR post-transplant for allergenic and autologous. We have few patients with autologous transplant who did have reactivation post-transplant, and a few of them diagnosed at a very late stage after they develop symptoms and disease because previously we were not testing for that. So we do weekly titer for the first 100 days, then every 3 weeks, every 2 to 3 weeks in high-risk groups. We initiate preemptive therapy at CMV DNA titer threshold above 1,000. Which is some centers they start at 500, some centers they start treatment at any positive titer, but for our patient we selected 1,000 because we have very high rate of seropositive in the recipient and donors. So the aim of this study was first thing to examine the treatment efficacy using a preemptive threshold of 1,000 copies per ml. Treatment efficacy was inferred from viral clearance and incidence of CMV disease. The second aim is to examine the incidence of spontaneous viral clearance in patients with lower level of viremia. So to see if patients with lower level than 1,000, how many of them will progress to develop titer above 1,000 or reactivation, and how many of them will develop disease, and how many of them will clear spontaneously. So in our transplant center, adult age is above 14, so we included all adult patients in the period from December 2018 until from November 2010 until December 2018, and the median age was 26 years old. The diagnosis, malignant and benign conditions are included, and we have different categories of risk factors. And regarding the donors, we have included match-related, match-unrelated, and haploidentical. In some patients, they received in vivo T-cell depletion. Majority of patients received myeloablative conditioning. So the serostatus here, recipient positive, donor positive, and 98%. 3 patients serostatus is negative, received cells from a donor positive, and 1 patient who has positive serostatus received cells from donor negative. So the reactivation, any titer happen, reactivation 91%. Only 28% reach level above 1,000, while 66% above 100 and 34% above 500. And the time to initial reactivation was 17 days. Those who require treatment with ganciclovir 45%, valganciclovir 55%. Only 1 patient from all group develops Cmv disease. 84% clear the reactivation, and time to clearance in median days 46 days. Secondary reactivation happened in 50%. In this table, older patients have a higher risk of higher viral load. Malignant indication for transplant have higher risk for reactivation with titer above 1,000. Donor type like MUD, haploidentical donor, or the use of T-cell suppression is associated with higher risk of reaching titer more than 1,000. ABO mismatch also is associated with high risk, and presence of GVHT, especially acute GVHT, is associated with high risk of titers reaching more than 1,000. And here the treatment for patient with CMV titer less than 1,000, only 1 patient required treatment, while 94% of patients more than 1,000 titer require treatment. And 93% of the patient with titer less than 1,000 cleared the reactivation, and 88% in the titer more than 1,000 cleared the reactivation. CMV disease, none of the CMV titer less than 1,000 developed disease, while only 1 patient with a titer more than 1,000 developed the disease. Secondary activation in 39% of patients with titer less than 1,000 and 65% in patients with titer more than 1,000. So the conclusion from this study, CMV reactivation post-stem cell transplant was very common in patients with high risk, high prevalence of seropositive status. Preemptive threshold of 1,000 copies per ml appears desirable, and it was associated with spontaneous clearance in over 90% of patients while minimizing the treatment-related toxicities. And here is the event-free survival and overall survival. The relapse, non-relapse related mortality was higher in patients with titer more than 1,000 compared to less than 1,000, and the overall survival was better in, but statistically not significant in low titer group. So I will mention some recommendations from the ECIL, the European Conference on Infection and Leukemia. So the first recommendation, this was from 2017, the first recommendation for pre-transplant testing of serological status. They recommend all recipient and donor should be tested to determine the serostatus before going for transplant. The second recommendation regarding the choice of donor based on cytomegalovirus serological status, a CMV seronegative donor should be chosen when possible for a CMV seronegative recipient. A CMV seropositive donor should be preferentially selected for a CMV seropositive recipient in the setting of unrelated transplant with myeloablative conditioning. In case of match-related donor, in case of haploidentical donor, a seropositive or seronegative donor is suitable for seropositive recipient undergoing haploidentical transplant with post-transplant cyclophosphamide. And the reason for this, there was no consistent effect has been observed of patient donor matching for cytomegalovirus serostatus after haploidentical transplant with using post-transplant cyclophosphamide. An analysis published in 2018 of almost 1,000 CMV positive patients found no significant effect with respect to non-relapse mortality and overall survival of donor status. The third recommendation regarding CMV and leukemia relapse, many retrospective studies reported that patients with CMV infection has less risk of CMV leukemia relapse. But there was a large multi-center study involving more than 9,000 patients showed no effect of CMV serology or infection on relapse was found. The fourth recommendation is regarding monitoring for cytomegalovirus in plasma and whole blood. So allergenic hematopoietic stem cell transplant recipient should be monitored for CMV in plasma and whole blood by BCR assay, which is more sensitive than BB65 antigenemia assay. Monitoring should be done at least weekly for the first 100 days after the transplant. Longer monitoring is recommended in patients with acute or chronic GVHD or those who experienced CMV reactivation, or in patients undergoing mismatched cord blood or haploidentical transplant, and those on long-term effective prophylaxis, or in those displaying persistent immunodeficiency. CMV DNA cutoff value for preemptive therapy should be adapted according to the monitoring technique used and the transplant method, or center-based. The next recommendation of pre-transplant testing of serology status, we mentioned this before. So the conclusion from the presentation: CMV infection is common and serious problem post hematopoietic stem cell transplant. Identification of high-risk patient and it needs aggressive approach. Preemptive approach is standard of care, and higher threshold 1,000 copies per ml to start treatment is acceptable, especially in low-risk patients. Thank you.
Thank you, Dr. Mohsen, for this very nice review, and thank you that you finish on time. I will postpone the question for your lecture to the end in order to have more questions. And now we can proceed with our second talk of today. Will be by Dr. Tamim Al-Sulaiman. Dr. Tamim Al-Sulaiman, he is attendant hematologist in St. Antonio Hospital, which is a famous hospital in Paris, which is a part of APHP group, university hospitals, which 39 hospital that I know from Dr. Tamim. And St. Antonio Hospital, the section of cell therapy department, Dr. Tamim is also a known author for many also research about transplant, and he gave talks about CMV previously. Dr. Tamim today will talk about the management in CMV in allergenic stem cell transplant with a specific insight from the French practice, or of the French center insight. Dr. Tamim, please proceed.
Thank you, Dr. Shaheen. Thank you, Dr. Zahrani for the nice talk and the nice introduction. Can I share my
Yes, please.
screen? Okay. Can you see?
Yes, we can see.
Yeah. So first of all, this is my conflict of interest, Moreira from Biotest.
Maybe Dr. Tamim, if you put the slides show.
Yeah,
one down,
I'm
maybe.
trying to do it.
Yes, perfect.
Yeah.
Yeah, now it's more clear. Thank you.
I think there's 3 seconds period between the act and the, yeah. So for CMV, it's a beta herpes virus, as Dr. Zahrani said, the same family as for HHV6. It's a large virus with likely 200 proteins. It can be presented in endothelial, epithelial, smooth muscles, and blood cells. I think, yeah. For its biology, it's a common virus in human populations, and many individuals may carry the virus by the time of adulthood, and it causes a lifelong latency in the host. We can say that compromised the immune system, such as for patients with low HSCT. In this case, CMV may be a serious risk for infection, activation, or reactivation, and even for CMV disease. It's one of the major issues in our settings. The prevalence is so variable, but we can say safely that adults in industrial countries, seropositivity is about 50%, maybe to 60% approximately, but can reach 90% in more developing countries. The problem can be also discussed from the point of view of immunoreconstitution after the LOHCT. Like if we have a patient with GVHD or has, as always, we do the GVHD prophylaxis. The immunosuppressions may facilitate the CMV reactivation. So we can say safely that if we have, and I think in the case of LOHCT, we will do the GVHD prophylaxis wisely. We are already at a high risk of CMV activation. Reactivation, but when we are treating the GVHD, if we have an ongoing GVHD, active GVHD, we are in a more higher risk of CMV reactivation, and we must keep it in mind when dealing with symptoms and also for routine monitoring. When we are talking about compromised immune system, we are talking specifically about the CMV specific response from CD8 positive cells, which may majorly predispose the patient to CMV infection. As Dr. Zahrani may mentioned before, the analysis of CMV or the methods to detect the CMV are very various. At our time, we are using the PCR to detect the virus, the genome of the virus. But before that, we had so many methods like the IGRAs, interferon gamma releasing assays, like quantiferon or CMV ELISpot, and especially for CMV ELISpot that quantify the CD4 positive and CD8 T cell response to CMV specific peptides. It was a good method in before the PCR to detect the CMV. But we must always keep in mind that we must use these approaches, the IGRAs, normally after the reconstitution, or after we have good reconstitution, because before that we may experience false negative results. We may use it before monthly for 3 to 12 months, not like PCR, which is more accessible, easier, and we can use it in a better way to detect the genome of the virus, maybe 1 to 2 times a week. It's so accessible and fast, rapid. Like for in France, I don't know in other countries, but in France we can get the results maybe in some hours. So it's very accessible and very rapid way to detect the problem. For the clinical representation, the CMV pneumonia is the most serious manifestation of CMV, and the mortality is more than 50%. If and maybe, like Dr. Azharani has said, be presented by fever, an unproductive cough, etc., etc. A negative PCR results can be used to rule out the diagnosis of CMV pneumonia. Maybe, but for the GI tract, it's something so different because of the problem of GVHD, the GI GVHD. So ulcers of CMV diseases are frequently misdiagnosed, and some examiners may relate it more to GVHD than to CMV disease. So it's a good point to keep in mind. The diagnosis of CMV disease, it's about the detection of CMV in biopsy specimen, but also we can roll it in PCR negative cases. For that, it's a little bit different from the CMV pneumonia. The CMV and GVHD are commonly and frequently associated concomitantly. So it's a second point to keep in mind, that if we are sure that we have a GI tract GVHD, that we cannot rule out very simply the CMV disease, because it can go together. So we have to maybe telephone to call the examiner, the pathologist, and say, can you please verify if there's a CMV, so we can go for the two goals together. For the retinitis, it's uncommon, like Dr. Azharani said. I will not talk about the loss of vision. It's highly probable, but also I have to mention that encephalitis from CMV can occur. So we are. It's also a good point to keep in mind for some cases, if we have some neurological manifestations after allo hematopoietic stem cell transplantation, we have also to go for or rule out at least the CMV in these patients. I'll go very quickly on the burden of Cytomegalovirus in allergenic hematopoietic stem cell transplantation with a good article from the Lille Center, Hospital Center. And they examined a little bit what it means to have some patients with CMV What it means from the point of view of the hospital, the healthcare system, the patient, and also the turnover of patients, because as you know, we haven't so much spaces for patients. So we have to keep in mind that as soon as we can facilitate the turnover of patients without compromising their health status, we must go in a reasonable way to do it, because this may facilitate the next allo HSCT for another patient. I don't know also the status in other countries, but I think the cost of the HSCT bed is so high in all countries. So I think we are using the same criteria always, without compromising the health status of the patient. So rapidly, they studied from the, we can see from the left column the results for the exposed CMV recipients, and the second column, the right column, is about the non-exposed recipients. And here we see the differences in days of hospitalization stay or hospital stay. And we can see that the difference is statistically very significant, from 42.5 days to in exposed patient to 23.3 in non-exposed, for over 3 months. For over 6 months, we have significant results, and over 12 months, we have also a significant difference between the exposed and non-exposed patients. As for the cumulative hospitalization cost in euro, we can say very easily, or see very easily, that the difference is significant between the exposed and non-exposed patients for over 3 months and over 6 months. After all, on over 12 months, we may not see the differences, but this may be due to other explanation that we can talk about it if we have the time after. For the hospital admissions, for over 3 months and 6 months, we can see easily that it's so different between the exposed and non-exposed patients. As a conclusion, CMV disease is associated with increased mortality and health resource utilization in allo-HSCT patients in France, and we must encourage the detection and the early management of this problem to ameliorate and enhance the quality of our services. I will go very fastly to talk a little bit about treatment. CMV infection treatment is commonly based on ganciclovir and foscavir. In a lesser extent, it's about drugs, including other drugs, including cidovivir. The Milo Toxicity in the case of ganciclovir, the renal function impairment in the case of foscavir and cidovivir may be the major issues for treatments, alongside the refractoriness of CMV in some cases. The treatment failure may present up to 45% of treatment episodes. The risk may be higher during the first-line treatment, And when we use the immunosuppression, the treatment failure may be due to drug resistance, as for mutations, and to the antiviral intolerance, leading to discontinuation of treatment. The drug resistance is not so common after allo, but we must suspect it in patients who increase the CMV load for more than 2 weeks despite a well-conducted therapy, and we must highlight the well-conducted therapy here. We can easily say that GCV and VGCV are the first line in 90% of centers that we know. So most studies about resistance are about these two drugs. I will go rapidly to talk a little bit about our guidelines. It's from the French Society of Bone Marrow Transplantation and Cell Therapy. We gather every year to discuss some issues, and every year we issue recommendations about different subjects. We've gathered and we've talked about the antiviral prophylaxis for some viruses after the HSCT. We've talked about risk factors, as Dr. Al-Zahrani said, for the early infection, the seropositive patients, myeloablative conditioning, in vivo or ex vivo T cell depletion, and the use of umbilical cord blood alongside with the presence of GVHD. For the late onset infections, it's the same categories, but we add the CMV infection history, which is logical. The complexity, we are talking about high cost infection in both ways when we are talking about the human cost, the resource cost, and the financial cost. We are talking about more fragile patients that we are experiencing grafting with days, with experience, all that. So we have to pay more attention to these complications that may impair the outcome, the HSCT outcome. The prophylaxis, we have recommended that letermovir for all CMV positive serology adult patients to be initiated is as soon as possible, as for day 1, because 16% of reactivations may happen in the first week. For the dosage, it's maybe 240 milligram per day if used with cyclosporine, and maybe up to 480 milligram per day without the cyclosporine. We've talked about how to stop letermovir, and when we've recommended to stop it at day 100, and to discuss continuing treatment if the patient is under corticotherapy for GVHD or in special cases. We have recommended the weekly monitoring of CMV charge under letermovir. Other prophylaxis options included acyclovir, valacyclovir, ganciclovir, and ganciclovir with valganciclovir with different levels of recommendation, as you can see here. It included also the foscarnet and the polyvalent IG. But the residual question was also about the place of CMV IG, that with a question mark to be resolved later. In another version of our recommendations, we have talked about the management of CMV reactivation and infection after allergenic. We have distributed a survey on some centers in France, and as you can see that most centers has used PCR to detect the CMV. The frequency was 2 times a week, and the duration of follow-up was from 100 days to 180 days after transplantation. As for 2016, no center has used a specific prophylaxis for CMV, which is, I think, logical also at the time. For the preemptive curative, it was the GCV or the FOS, while it was also like when we talk about GCV, we are talking also about VGCV. It depends. What's about how to stop treatment? We can say that 11 out of 17 centers has used the criteria to have 2 negative PCRs before discontinuation of treatment. For the prevention, I will not repeat what Dr. Al-Zahrani has said. It's about matching between seronegative from donors to patients, to recipients. And as for our status from the transfusion, as for dolichocytation is generalized in France, we have said that no need for CMV negative products in France. So I think I don't know the status in other countries, but in France we have said that no need for the CMV negative products. For the follow-up, we have highlighted that we must use the quantitative PCR or antigenemia with weekly rhythm up to day 100 post HSCT, and maybe 2 times if we are in a special setting, like because the doubling time of viral charge is from 24 to 48 hours. So we must keep that in mind. If we have chronic GVHD and the immunosuppressors are always used, or we have a bad reconstitution of T cells, the follow-up must be longer. We have talked about the definitions. I will not repeat also, but I have to highlight that we've talked that viremia alone cannot apply the disease. How to treat, Dr. Al-Zahrani has illustrated. For the preemptive treatment, it was GCV. For the first line, VGCV can be used also. And the failure is the stability or the augmentation of PCR 15 days after a good treatment initiation. The second line, we've talked about GCV if we have used foscarnet in the first line, foscarnet if you have used GCV in first one. We have talked about alternatives like Sadovivir, hyperimmune anti-CMV like Cytotec CP. For the third line treatment, we have talked about the association between GCV and foscarnet. In alternatives, we have like in ATU, the HD artesunate, Sadovivir, AVIG, hyperimmune anti-CMV, and other like that days, the clinical studies like maribavir, letermovir in that days, in those days. The curative is identical, treatment is identical to preemptive treatment, but total duration of 3 weeks minimum, with also maintenance therapy that must follow the preemptive treatment if second reactivation, and always after the curative treatment from 2 to 4 weeks with a half dose of the treatment that used in the first line or in the precedent line. We have talked about antiviral dosing. I will go a little bit faster. The SL7 was illustrated by my colleague, so I will just skip it a little bit and go directly to the CMV IVG, which is limited in most, its use is most limited in French centers to the salvage therapy for recurrent and refractory infections, and in some cases in combination with other treatments. We have published this article on 2018 in BMT, and we've talked about Cytotect as a salvage therapy in patients with CNP infection following Allergenic Hematopoietic cell transplantation. It was a multi-center retrospective study with 23 patients with a profile of high risk, as you can see here from red lines. You can see that most of patients were under immunosuppressors, like 91% of them. We can say that 17 out of 23 has grade 2 to 4 acute GVHD. And we can say also that 17 out of 20 of them has a second or more episode of Cytotect before. We can see here that it was used as a monotherapy or combination with ganciclovir or foscavir or ganciclovir and foscavir, and also with other combinations. We have used the prophylactic, as we called it in France, dose for or scheme as 200 units per kilogram every 3 weeks for 3 patients, and the preemptive scheme for 400 units by kilogram on day 1, 4, 8, then 200 units per kilogram on days 12 and 16 for 20 patients, for most of patients. So, and we can see here that the negative CMV PCR was documented in 70% of patients, the VGPR in 4%, persistent negative CMV PCR in 4%, and the failure in 18%. We can see here that for the overall survival, the P was not significant. I don't know if it's about also the number of patients, that we have a small series of patients, so it's not so easy to establish a p-value, a significant p-value. As a conclusion, the major points for us that the safety profile of CMV IVG was something to keep in mind because of the problematic of multi-treated patients after HSCT, as for some immunosuppressors for GVHD, or for some antibiotics or antifungal treatments after HSCT that may complicate that situation, as for the renal impairment and Milo Toxicity. And we've talked also that it seems to be an option to consider as a salvage therapy in CMV infection after HSCT. I will not talk because I'm short of time, I think. about the CMV IVG in solid organ transplantation. But you can see this good article after it's so recent. It was published in 2021, and it illustrates the use of CMV IVIG in solid organ transplantation. As for me, I think I will thank you for your patience, and I'll go to our honorable moderator and colleague.
Thank you, Dr. Tamim. The audience like your slides. Actually, I received already a WhatsApp request of the slides because I think you was a little fast also, and there was a lot of very important information in your slides. So take your permission later. If you agree, we can distribute. Thank you, Dr. Tamim, for this nice review of the management, and very interesting really to have to know. Like for me, it was very interesting that everyone with the seropositive, which all Saudi Arabia patient or donor actually, as Dr. Mohsen mentioned, 100%. Rarely we saw like zero negative. So all are in a letermovir prophylaxis.
As for recommendations from the SSBMTC, the French Society of Bone Marrow Transplantation and Cell Therapy, as you've seen, we have recommended it. I think the rationale is there is no criteria to differentiate between patients in these settings. So why you will give letermovir for someone and say no to someone else? There is no rationale.
Our issue is the cost with this medication. We try to request, it's still not formulary, but we try to request for ultra high risk of CMV. So I'll go with the question. So first question to Dr. Mohsen. Dr. Mohsen, in your center, you said you recommended, you are doing weekly test till the 100. Any problem with the during the COVID era because it's the same machine? And for example, in my hospital, they delay our results because the machine was very busy with COVID PCR, same machine. So do you face any issue with that?
Yeah, so thank you for the question. We had problems last year with the results of CMV testing with the delayed reporting. They accept to do it weekly, bi-weekly, but the problem is the reporting is sometimes take time, 2 weeks. Sometimes we have to call them to release the report, especially for the high-risk patient. So we start to even reduce the number of the testing to reduce the load on the lab. But this year they are back to normal, and we don't face anything lately this year.
We have like a contract with the lab in our hospital 2 days, but as you know, recently, no, they are not following. So Dr. Tamim, in your center, every patient will get the results after a few hours, like 12-hour maximum 1 day, or only if you call?
I think we have it by our system, our computer system. And I think our lab technicians and biologists are so aware of the problem that if they detect something weird and they see the curve of CMV, and they may try to alert us by telephone if they seen something like this. Maybe even more earlier.
Perfect. So, Dr. Tamim, a question about the IVIG, particular the specific one for CMV. You put the dose of 400 units per kilo. This is considered a high dose versus low dose. So, what's your experience? I saw that 20 patients received 400 units. So in your experience, you advise really to have high dose?
As for France, it's a little bit special consideration, because we have cytotoxicity as a part of a program which called ATU. That is the temporary authorization and nominative authorization. For that, we have schedules that must be applied for every patient very strictly. Those for ATU, I think, were established before many years, based on some experience and on some also bibliography rationale that came from Black Love publishing. I think our article, you may search for it. It's from the 80s, but they used easily the high rates of high titers of CMV IG. As you can see from the article, yeah, it worked for 70, almost 70% of our patients, with salvage therapy, with the patients complicated with most of them with acute GVHD. So I don't say that it's the as we say in France, the baguette magique, the magic
Therapy.
approach. It's not magic at all, but it's
One of the
another.
weapons. One of the
Yeah, it's
weapons.
another weapon in our arsenal. Like
Especially
exactly.
in very sick patient like pneumonia and or like you mentioned gastritis with like GVHD and you not know. Another question for Dr. Mohsen. Do you believe that foscarnet is less myelosuppressive? Because there was a question about foscarnet as an upfront therapy when you use it.
Yes, of course, it is less myelosuppressive than ganciclovir and valganciclovir, and actually we use it in patients who have reactivation even before the engraftment, or in very high risk patient, for example, patient with previous graft failure. So any issues with the graft, we use foscarnet instead of ganciclovir or valganciclovir.
And especially early, as you mentioned.
Yeah.
The other thing, like this question for Dr. Tamim, when you use valganciclovir, again, it's very myelosuppressive. Sometimes we use in most of our patients 450 twice, like 450 in the morning, 450, only one tablet. Are you familiar with this, or this is your practice? So in France, you give a small dose or you adjust the dose?
As for Milo toxicity, I think we have a wide arsenal of treatments for CMV that didn't include valganciclovir. So we are a little bit maybe more free from these limitations. But I think that, like I've highlighted in my slides, it's my personal point of view. If we can, we must really adhere to a well-conducted treatment to be very really efficient. Yeah,
we use it. Actually, we discharge many patients on valganciclovir. It's well tolerated, let's say. The other thing about our in pediatric, our colleague in pediatric, they send every patient with CMV, antigenemia, or reactivation of CMV to ophthalmologist as part of the workup. In adult, we are doing this, but not routine. So, are you sending all CMV reactivation to ophthalmologist to confirm or rule out retinitis, or only with symptoms?
With symptoms, with patients maybe with high titers, high CMV titers, with patients with long-lasting CMV infection, recurrent, maybe also refractory patients. I think it's logical to send those patients to a good ophthalmologist, because they must be very experienced in the area to really to detect. If you have an ophthalmologist and they are interested in your center, like in many centers in France, I think they request. I've met some of them. They request that we call them on patients with CMV, because they are trying to be experienced in the area. So why not? If you have them, why not?
Dr. Mohsen, are you doing send routinely to those two ophthalmologists?
No, only if they have any suspicion, any symptoms, blurred vision, any visual symptoms, we send them for ophthalmology, and we have very good ophthalmologists who pick up some cases and reported them to us, and he treated them.
And Dr. Mohsen, did you use the letermovir in your center?
We don't have it, unfortunately. We have very ultra-high risk patients. We wish that we have the drug, but unfortunately we don't have it. It's very expensive, not registered.
I think it will register soon, I think, in SD or one of the companies. Dr. Mohsen, you have any experience with the IVIG, CMV IVIG? The specific
it is available in our center, used mainly by pediatric colleague. We use it, I remember we used it for patients with CMV pneumonitis, but we did not reach into the stage of like third line or to use it. So basically most of the patients, they respond to the antiviral.
Yeah, so like in particular patients, so who refractory, I think we used it in King Faisal, but long time ago for pneumonia as well.
Yeah.
And there is even the meta-analysis, maybe Dr. Tamim can comment on this. In the meta-analysis, which is published, I think 2019, they review 30 study, but all of them before 2003, like from 1980 to 2000, and 26 of the 30 study that included was in sibling. So no new, they didn't put the era of the haplo and the era of even the more mud in those particular, and also some of the study was not the specific IVIG. So I think we need more study, prospective study. I think your center is working on now a prospective study, I heard.
I think it's of Professor Egubaga mainly, who is initiating this good protocol, phase 2, I think, study about this, no description, I think. So we hope that this study will show us really the results, if beneficial or not. It will, I think, resolve the problem. Like you have said, the problem that the meta-analysis is very heterogeneous in data, and we cannot really. I don't dare to conclude from it about the cytotoxic CP, because it was not the approach in many of studies included in the meta-analysis. As I said, I'm just stating from my point of view, doing this retrospective study, that we have shown the safety profile, the use in some patients, but the question stands unless Professor Egubaga and his colleagues answer us about it by the prospective study. Yeah.
Last question from Dr. Mustafa Saleh. He asked about the dual therapy. When to use two therapy at the same time, dual therapy?
And I'll just illustrate one scenario. If therapy from for CMV was doing good, and the breaks are in place. So the CMV load is now about 2 logs or something like this, but the patient is high risk, and we want really to a clearance of CMV load after many lines of treatment. A combination, maybe the adding something
Second
to
one.
a second one, or a CMV-IG with a good profile. I'm talking just about the study that we published. Also, if we are talking about a reduced dose therapy for some reason, medical reason, maybe some doctors will go with a combination therapy with another with CMV-IG with a good safety profile, in order to ameliorate a little bit the efficiency of treatment and stay to be efficient as if we were in the regular dosage treatment, and etc. etc. Like in some cases with after 3-4 lines of treatment, we are some way out of our arsenal, so we try to combine some of drugs which worked in a while, and after that failed, to combine together with a good consideration to safety profile. Our patients don't need really another burden on them, so we may consider or discuss these cases.
Inshallah. Dr. Mohsen, anything you want to add or add?
Just a question to both of you. What titer do you use for preemptive therapy?
So in our center, we use the plasma. They use the PCR with the plasma. And we decided to go depend on the high risk of the patient. So in ultra high risk, we'll use 500. In a non-high risk, 1,000. Because the reason why we go to 1,000 nowadays, because we discover that many of the patients will require more treatment than required, which will build up resistance, and we notice that sometimes we overtreat. Still, of course, in high-risk patients, GVHD, the T-cell depleted transplant, still we go by 500 copies. What's the situation, Dr. Tamim? We are talking about the PCR, yeah.
Yeah, in France, we are talking always about, almost always about the PCR. The French Society have stated that it maybe will be discussed about 3 lakhs when we are reaching 3 lakhs. In 3 point something lakhs, we may really consider the treatment, and on 4 lakhs, there is no discussion that we must initiate our treatment. That was the answer for our centers. It was a question for us, and we have answered it in our recommendations.
I think I want to thank really everyone, the speakers, and the SSBMT, Saudi Society of Bone Marrow Transplant, for doing all this very nice webinar. Today webinar is sponsored by Biotest, and the previous webinar, because this is the last webinar, I want really to thank all our sponsors who help to give the education to our colleagues. Premium sponsor with Johnson, and then Sanofi, Biologic, Amgen, Takeda, Gilead, Kyowa, Chiron, and Biotest. This is the last one of this year, but we will again, come back, inshallah, mid-January 2022 with a new series, with the new topics, inshallah. And I want to thank all SSBMT organizers and the webinar help, Noor, Kaya, everyone know her, and Dr. Prof. Ahmed Al-Askar. And inshallah, we'll see you soon. Dr. Tamim, this is a lake of Anas. What is the name of the lake behind you?
Ansi.
Ansi, very nice lake. Inshallah, hope to visit one day, inshallah.
Inshallah.
And have a nice day, everyone, and see you, inshallah, in the future. Thank you.
Thank you very much.
Thank you very much.
Thank you very much.
Amanallah. Ma salam.
Assalam.